I'm General Sandifer, and I work and lead the podcast team. We're happy to have each of you with us today on our African American Network, Kern County and Buffalo Soldiers podcast. And I want to welcome each of you with us. I know you're taking out your precious time to come on to our podcast that we do monthly, by the way, and share your expertise and your answers and responses to our questions. And so what I'm going to do is to turn it over to Captain Stowe, who will serve as our moderator, and want to welcome her. And again, welcome to each of you. We appreciate you for your sacrifice and your commitment to what we're doing here at the African American Network and Buffalo Soldiers. So Captain Stowe, it's all yours, ma'am.
Thank you so much, Brigadier General. So good afternoon to everyone here, and thank you again for joining us for our podcast today. The subject of our podcast today is health equity and access to care within the African American community and people of color. But before we get into the questions and the prelude to the questions, I just want to introduce each of our guests and give them an opportunity to introduce themselves. Tell us a little bit about yourself and why health equity within the community is important to you. So we're going to start off with Mr. Traco Matthews. He is the California Racial Equity Commissioner and Chief Health Equity Officer of Kern Health Systems.
Well, thank you so much for the kind introduction. Traco Matthews, recently appointed to the state's first Racial Equity Commission by Governor Newsom, and also the Chief Health Equity Officer at Kern Health Systems. Just briefly, this work is incredibly important to me personally because of lived experiences. Obviously I've been a Black man for 45 years, all my life, and growing up in Fresno and the Central Valley, I have personally experienced racial disparities and inequities. My family members, my wife, will probably get into some of that as well during childbirth. We have stories to talk about that are personal to us, but also because I see the data and some of the disparities in healthcare and across sectors, and I'm someone who wants to help create a better society and a better world. So that's why I do this work. Right now, I happen to be being paid for it as a Chief Health Equity Officer, but I plan to do this work for the rest of my life. Even as a volunteer once I'm long retired. Thank you so much.
That's so wonderful. Thank you. Thank you. And next will be Dr. Crystal Jackson. She's councilwoman for the city of Tulare and president of the NAACP for the Kings and Tulare County chapters. Mrs. Jackson.
Good afternoon, everyone. Dr. Crystal Jackson. I love that you all give me the title of councilwoman, but I'm not the councilwoman. I think you guys are trying to push me into that seat. But I am the Community College Board of Trustee, as well as the president of the NAACP and many other titles. But here in the community, health equity, it rings high with me because I watch a lot of people every day that can't either afford insurance, or the insurance carrier doesn't allow for them to get the necessary care that they need. So one of the things that we try to do within the NAACP is to provide those resources through, I look at several different issues that are going on within the community. So the pandemic of overdosing, recently worked with the health department to get Narcan, where we could distribute those through our different health awareness fairs and stuff. It rings true to me because when I was young and growing up on the East Coast, my mom used to tell me, unless your leg is broken and I can see the bone coming out, I'm not taking you to the emergency room. So I always grew up with the mentality that you couldn't go and receive care. It wasn't until I went into the military and I started to get the necessary care that I needed, that I saw that there was a true issue going on within not just the community, but within the country, nationwide, with the issue of health equity. It comes down to poverty, and a lot of other different issues that I'm sure we'll get into later on. So I'll just stay right there. Thank you.
Thank you. And Dr. Nikki Rodriguez, she is formerly working for Centric Health as a practicing family medicine physician.
Well, thank you for having me here. I think like from my background, personally, I can relate to the health issues that are going on, the access of care. Even as a physician, I'm from, my mom is Mexican. So I had faced a lot of inequality, even trying to get to become a doctor in almost every step. And I feel passionate about it. And I feel like when we look at the physicians who are leading one integral part of this, health inequality and access to medicine, that we need to educate the physicians out there. Because when we look at the statistics, there's only about 5% of the physicians are African American, Black, or of Hispanic origin. And so just my little background, graduated from Emory out in Georgia. So I practiced out in the South for a while with a family medicine and public health residency. And then I moved about 7 years ago to Kern County. And I'm practicing family medicine and urgent care, where I provide care throughout every part of the Kern County in the urgent care setting.
Thank you so much. Thank you all so much for your stories. They're very powerful, or I should say life experiences, and it kind of gives us an idea of why this topic is very, very much very important to you all, and I appreciate that. So we're going to get into the prelude, and the African American health equity is a very important topic, and we are so pleased, as I said, to be able to talk about it this afternoon. It is important from both an equity and a public health perspective. The subject of this podcast centers on the critical issue of health equity and access to care within the African American community and among people of color. Historically, African Americans and people of color have faced persistent disparities in health and healthcare. While healthcare technologies and treatments have advanced, the accessibility and availability of quality healthcare for these communities have regrettably diminished. In today's discussion, we will delve into the disparities in health and healthcare, specifically in relation to African Americans and people of color. We will explore ideas and solutions aimed at improving healthcare outcomes and fostering greater equity in this vital domain. So we're going to start with the first question of the podcast. And the first question, it's a yes or no question, but I'm going to make it a little two-parter just to get a little deeper into that question. So the first question is, in addressing health disparities within the African American community, do you believe that a multifaceted approach is necessary to effectively reduce these disparities? It's a yes or no question, but I'd love to hear your supporting reasons as to why you think either or. And we'll start with Dr. Rodriguez.
The answer is yes. And the reason why is we'll start with like just the communities as we know them. We have out, especially in this area, rural communities, and we have our city of Bakersfield. And if you look at the rural communities and what they're made of, and the access to care, it is not that much. A lot of them are suffering. They do not realize that they need a primary care. The access to primary care has been, even if they are given health insurance, they have the knowledge that how am I going to get to my primary care? When am I supposed to be there? So I think a lot of it is in the getting the message to the community, and also I feel that it's delivered well with not only a physician needs to be there, because a lot of times, people don't want to listen to a physician in the sense of the way they talk to people. I think there's a lot of education that needs to be done through the community, with physicians being more active in this talk, and a face to it. And maybe the delivery of it would be very good having like a third party there. So having, say a community leader in a neutral space. Like a lot of times when you're trying to deliver care in a room where you're already talking about 5 other problems they have and saying that you need a screening for colon cancer, that message wasn't delivered well by the physician. It really needed to be delivered in different ways. And we need to have positive talks, not always negative talks about what the healthcare system can do for them. And I think that's really, really important. The multifaceted portion includes the community churches, the community leaders, and also just the citizens themselves. There's a lot of prominent citizens that are able to talk to the peers and be able to reach them in a level that I can't reach. And I feel that's important to do an involvement, but really get the providers out there, our physician assistants, our nurses, to have a more of a voice out there. And they have to want to do this because we want to see the change happen. It's been going on for, I think COVID kind of brought it out, with the disparities there. To me, it was life-changing after COVID and during it. But it was there before COVID, and it's been there since probably we can go back into the 1940s and 1960s, this disparities, easily talk about that. Mm-hmm.
Thank you. Thank you so much. So we're going to go to the next same question, but we're going to go to Mr. Trayco Matthews.
And Dr. Rodriguez shared many of the same points that I would highlight. The answer is yes. We have to look at a lot of different things. And I like to start from a couple of slices. First, almost high level. Whenever you're talking about social change, we've had a lot of really good laws related to civil rights and even health equity for, as Dr. Rodriguez was saying, years. So it's not enough to have laws on paper. Then once you have laws on paper, you need what I like to call leadership. That means people who are in communities making it so. And, that's up to us. It really doesn't matter what the Constitution says or what the state of California's laws say. If we don't have communities that are willing to effectuate those laws and actually make them happen. And so, because so much of this is discretionary, you can't force people to welcome Black patients into their clinics, hospitals, or anything else. And so if you treat them wrong, guess what? You're not going to have trust. And we'll talk about that later. But suddenly, quote unquote, they're not going to be as healthy. They're not going to get their wellness checks, et cetera. And then everyone's going to wonder, why are they dying at higher rates? What's going on with our Black mothers? And so it's got to be a combination of both. So it's got to be multifaceted in the sense that you got to have the right laws and regulations in place, but then you got to have the right leadership in place as well. And that's critically important. But then you do have these other issues, and often in the health equity or quality care space, we just refer to them as social determinants or social drivers of health. What that says at a high level is that, someone's wellness, their overall comprehensive health for a person, it has a lot to do with the clinical access that they have access to. So if they have good doctors, fantastic, that's wonderful. But really, the research is starting to tell us, depending on what you look at, and COVID really did drive home the point too, probably somewhere between 70 to 80% of a person's overall care really has nothing to do with their doctor or the clinical resources they have access to, the clinical care. It has everything to do with all the other stuff, the peripheral stuff that for a long time we have really just devalued or not really thought was important. Things like transportation, socioeconomic status, education, awareness, cultural competence, and how information is communicated. All of these other factors. That's why I have a job. health equity is about not just the clinical quality side of the care, all the other attributes and different things, elements that we have to consider for an individual person. And so that's why I would say, yeah, definitely the answer is yes. And you could take many, many slices and go down some pretty deep rabbit holes on each of them.
Thank you so much. Thank you. Dr. Jackson, we'd love to hear your view on this as well.
My answer is yes as well. And I say yes because pretty much everybody has already spoken on in detail, but we have to raise awareness through education and that way that you could actually help to address the equity, improving the resource coordination. That can also help the populations because it also begins with trust. And if you don't trust the physicians, and that is what happens a lot of times when people go in, they do not want to, they don't feel that they need to go and see a physician because, they're just going to tell me this or they're just going to tell me that. So they can help reduce the ethnic health disparities by offering cultural competency training to help the care providers as well as helping the community through different organizations that they feel like they can connect more with. So that's my response.
And I just want to let everyone know, Buffalo Soldiers and anyone that's on the podcast, feel free if you have questions, after each question or just to ask your question. You can raise your hand or just let me know. Thanks for joining. We appreciate having you here. So we're going to move on to the next question. The next question is, what strategies or initiatives can be implemented to enhance access to quality healthcare and improve the accuracy of diagnoses for patients within the African American community? And I am going to push that question first over to Dr. Rodriguez.
Yes, very good question. I actually worked in this type of a field when I first graduated in Atlanta, Georgia. So I worked for a company called GenCare. I don't know if anybody has heard of it before. It's a patient-centered medical home, and it's really in the areas of need of medical care, targeting a lot of times the African-American community in Atlanta, and then in Florida, the Hispanic community is focused there. What that does is that they actually go into the community, like door to door, and they sign them up for this healthcare plan where they will have a doctor where they can go drive themselves, or a van will pick them up. They have 24-hour access to a physician because we were able to take call. We had a large force of physicians take call very frequently. And we also had ambulances that could intervene, and we could give direction before even hitting an emergency room. So we, in that way, even avoided hospitalization. We also had a rule. You're going to see your doctor no matter what. So whatever scheduled appointments there were, we had walk-in as well. And that, to me, that worked out very well because we got to know our patients. We had very small panels of them, so we got to know them. And we also gave them their medications. We were able to dispense medications in that state if they were closed up already, sealed. So I knew that they were going to get that medication that day. I knew that when they come back, if they didn't ask or didn't pick up their next one, I knew that they were out of it and how long of a period they didn't have their medicine. And then we could discuss what were the factors that led to that. And so I think that kind of model definitely needs to be utilized more in all over the United States.
Thank you. Thank you so much. Dr. Jackson, what strategies or initiatives can be implemented to enhance access to quality healthcare and improve the accuracy of diagnoses for patients within the African community? I read it again because it's a long question, so I just want to make sure.
That's okay. It is long. it is a long question. So am I unmuted? Are
Yes,
you
we
able
can
to
hear
hear
you.
me? Okay. Well, raising awareness with health among the healthcare providers, we can improve this by having those conversations. Our public leaders can have those conversations with healthcare teams and providers. For example, the healthcare organizations, they can help reduce the ethnic disparities by offering the cultural competency training to help the providers, because sometimes the providers just don't know. And it's not for lack of a better term of saying ignorance. It's just that they do not know. You cannot relate. And so by entertaining the thought of having those conversations, this will help include the initiatives to raise the awareness through different levels of persuasiveness and inequities in health, and build empathy and support for addressing inequities, and enhance the capacity of the individuals within the community, which will gain trust and actively participating in the intervention efforts on a larger scale, for efforts to reduce the racial prejudices that are happening today. And those are some of the things that the NAACP, the health committee, those are some of the things that we are actively involved with in the community.
Thank you so much, Dr. Jackson, for sharing. Mr. Tracho-Matthews, same question. What strategies or initiatives can be implemented to enhance access to quality healthcare and improve the accuracy of diagnoses for patients within the African American community?
Absolutely. And before I share, I just have to point out Dr. Jackson and Dr. Rodriguez are crushing it with their answers. And so I'm not going to touch at all on some of the things they said. There might be overlap because I think these things are interwoven. But the one area where I would maybe focus is what we term, quote unquote, network adequacy. And really, there are two definitions. That means you got to make sure there are enough doctors, physicians, nurses, et cetera, around for people to have good access. But that's not enough. Then you also need to have good diversity and solid representation, because the research for years has shown that, quote unquote, concordant care, that means if I'm a Black patient and I have access to doctors that look like me, understand my culture, understand my lived experiences, for one, the trust that I have in them is probably going to be higher, and the way they treat me is going to be better. So that type of clinical care that is concordant and aligned with the different populations is critically important. So really, it's about, a recruiting strategy. And what's challenging is in a rural community in Kern County, you don't naturally have a lot of folks that are beating down doors to come live here and practice here. There are some systemic racial issues associated with that. I have stories that I can't talk about today because we don't have the time. But what it means is that as providers, hospitals, managed care plans, et cetera, we have to be intentional. If folks aren't going to be coming to us, we have to go to them and find ways to attract them to our community, recruit them to Bakersfield, to Kern County, welcome them with open arms. So then when you have greater representation, African American doctors and nurses and practitioners here in the community, the chances are much, much higher that Black patients, Black members are going to receive better quality healthcare. And so that's one strategy that we've tried to initiate and do here at Kern Health Systems. But I know that many managed care plans and other organizations have tried to do similar things, because the research shows that's a strategy that has proven to be successful.
Thank you. Thank you so much. I'm going to pause for just a second to see if there are any questions from those who are on the panel. Brigadier General Everly.
One of the bills that I think we should discuss is not necessarily, it's the most important thing, I think, is the first contact person that a person comes in contact with. And that being the gatekeeper, whether it be the eligibility worker or the caseworker, and their role in designating what happens after that, right? And that's the person who is so key in this whole process. I went through a thing with my mother, and I realized that if that caseworker is not working with you, that eligibility worker is not working with you, then everything that follows behind that is just not going to happen. You put in a claim and it gets disapproved. Now, whether or not you have a doctor or good doctors or a bad doctor doesn't matter, because you're not qualified for that program. And there has to be a way that when people have a grievance with that gatekeeper, right, who's going to decide what they get and what they don't get, there has to be a mechanism so that that person gets some relief if that decision is not in their best interest.
Mr. Matthews. You're on mute.
My apologies. I tried to unmute. I can respond to that because I think it aligns a little bit with my last answer. And the research does show that concordant care, it really must be top to bottom. So that means if it's a clinic and the provider happens to be, a minority, African American, that's probably not enough. You also need staff, or as you were saying, caseworkers, gatekeepers, other people who are that first point of contact, who also have that empathy, that lived experience, that cultural competence that is so critical to a positive experience overall. There are also, that's a whole rabbit hole in terms of how grievances are handled and recourse and so forth. But across the board, that's why representation matters so much. But also, representation is not enough by itself. The reason I say that is specifically here in Kern County, African Americans make up, I think, 5.5% of the population. We're not going to have a Black gatekeeper at every clinic, and it's probably not appropriate. There should be representation that somewhat mirrors and reflects the population of Bakersfield, Kern County. So what that also means is that's why the culture must shift. Dr. Jackson was speaking about it earlier. That training is so critical, so important. It means that no matter where you go, if you're Black, whichever clinic you go to, whichever urgent care, whichever hospital, all of the gatekeepers need to have the same heart that is welcoming and warm and open for people from all backgrounds, races, ethnicities, languages, etc. And that's a training issue. That's a culture shift concept that is probably only going to happen as we create greater awareness and train folks differently. So it's a both and strategy. You need strong representation and that concordant care, but you also do have to continue to train people across the board of all backgrounds and races who are in the medical industry to have just a different mindset and different hearts.
And can I add one thing too? I feel like when we start training these people, that they need to know that there's like a connection of trust that needs to be done, and it needs to be constant. And the patient needs to be able to have a voice during this process, because it's going to be a difficult one to change the mindset of some of these people who've been practicing for a long time, or just the culture of medicine. So we need to have the patient be able to, at all levels of this, express their concerns, the good experiences, the ones that worried them, and reflect on those. And the patient needs to know that they can do this and that they will be heard, because that's the only way I think change will come.
Thank you. Thank you so much, Brigadier Everly, for your question, and thank you guys for your answers. They were both. Sandra?
Just a slight sidebar. I also just want to point out the importance of educating our youth as a potential solution. As we know, these disparities have existed for many, many years. For example, as Dr. Jackson said, she was raised by her mother to avoid the emergency room unless she was in dire need of critical care, right? So perhaps by relating to or educating very young people, maybe by investing more in our education system or actively approaching schools, maybe we can have young people more educated and over time create a cycle of increased awareness in regards to healthcare. So just a tiny thing that I wanted to add in.
I think that's an awesome point. Thank you so much for sharing that with us. Thank you so
Thank you.
much. So our next question will be, could you discuss the impact of distrust among African Americans toward the healthcare system and healthcare providers on their overall health? Furthermore, what steps can be taken to rebuild the trust within the African American community regarding healthcare and healthcare providers? I'm going to start that question with Dr. Crystal Jackson.
Well, there are many reasons why African Americans they have come to the level of distrust. It's the burden of disease, injuries, death, disability compared to our European Americans. The health services are less frequently than our Euro Americans, and their underuse of services comes from the fact that they really don't understand and know all the different services of what it means. You know, each year you have your insurance that comes out. They give you this huge book, and they really don't understand everything that is in that book and what it entails to so they just leave their benefits the same, not knowing that for that same price, perhaps, all these other things are included in your Medicare, in your Aetna, or whatever Kaiser or whoever that you are seeking services from. So therefore, it's essential to understand the African American patients, their perspectives, and in their experiences with healthcare providers. We've had in past studies shown that there are 4 different barriers that affect the quality of patient-provider relationships between African Americans: perceived discrimination, medical distrust, racial discordance, and poor communication. The studies have not looked at how these barriers manifest when the African Americans speak about their different perspectives and their experiences with the care providers. Just like there's frustrations within the African American community, there are those same frustrations within the providers, the health providers, especially in the mental health area. There are frustrations as well because of those perceived the perception of what an African American is or what they are set up to be. You know, they have been profiled as being angry. They are profiled as struggling. They are profiled as many other things, and that, you know, they can't afford to eat. So therefore, that's why they eat what they can, and their diet suffers from that because they can't buy the correct and get the nutritions that they need, resulting in diabetes or hypertension or both. So I think the deductive approach would enhance both the doctors and the African American patients.
Thank you so much, Dr. Jackson. Thank you so much. We're going to go next to Dr. Rodriguez.
Yes, I I think this mistrust is very valid. It has to be validated. If you read about it historically, it goes back to the Tuskegee in Alabama, the experiments that were done on African Americans. They did not even know that with syphilis, and that's and then it passes down from generation to generation. There has been attempts to try to fix this by saying, I remember Bill Clinton, our president, apologizing for it. But yet there's still a deep mistrust because we know what went on, and we can see other things that are similar still occurring. So like we look at the death rate of cancer, say breast cancer in African American women. It's higher than whites. Why? Is it because they didn't get the screening? They were diagnosed later? You know, you can't say that they have more aggressive in that case. And if you look at it, the rates of cancer are higher in white Caucasians, but the death rate's higher in African American women. You know, and so everybody knows probably somebody who has had breast cancer or has passed of it. And so this is very personal to a lot of people where they've lost somebody from that. And then when we see the rates of it, there's a lot of distrust that comes with that because they personally suffered from the effects of what, say, cancer has occurred. It goes on with even other things in the community with regards to medications, you know, hypertension, we call it the silent killer. Sometimes you could say to somebody, you have high blood pressure, but they don't feel it. And then you give them a medication. How do they know that the medication that I'm giving them is going to be safe for them? You know, I could tell that to them, but sometimes we are given medications in the past where there's recalls and some medications that are not safe to be given. And so a lot of it is the health literacy and education, and I think a cultural change. So it's multifaceted in that approach. But I think the distrust is there, and I think the patients want to have trust. They want us to tell them and more and speak to them and give them that time. And I think also when it comes from the community, from peers, how they feel like, say, they had a great experience at this clinic, and then they talk to like the peer to peer. I think that says a lot too, that they're more likely, say, at a school setting or a church setting to have a mobile mammogram unit. I think that you're going to get a higher and more positive response than you are from the provider doing it. Because in that setting, it may have been a negative experience with the staff or something in that area where they're not thinking, or they were just educated for the last 20 minutes on diabetes and their mind is enough. They don't need to hear the next thing. So I think that a lot of that is within everybody who's gone to physicians, but more so with the African American community, that level of distress is there and needs to be acknowledged. And we need to have cultural training. Even with I like the point that we talk about education and recruitment of even starting at like a high school level classes, that health classes, and giving them opportunities to have becoming a nurse in this amount of time, giving them those vocational training and the abilities to move their way up. And because they're most likely people who are educated in their communities and become physicians or physician assistants, nurses, are more likely to come back to their community to help. And we know that, so we need to use that to our advantage.
Thank you so much, Dr. Rodriguez. That was very insightful. Thank you. Next, we'll have Mr. Traco Matthews.
Yeah, no, thank you so much. And I mentioned that I have stories, personal stories, myself, my wife, family members. But I'll start. I had the opportunity to speak on a panel a couple of Thursdays ago with the director for the Department of Managed Care for the state, and some other, folks in the room who they are looking at this all the time, and they brought some really good research, and it kind of hit me while I was literally sitting there because they showed a graphic for Black women and just different age ranges, 25 to 34, 35 to 44, 45 to 54, et cetera. And the ones who were most reticent to just get the regular wellness checks, annual conversation with their personal care physicians were in the age range of my wife. And I almost started to tear up because my mind immediately went back to 7 years ago when we were pregnant after 15 years of marriage with our first child. And through the pregnancy, my wife almost died. And I'll share a little bit about that story and what happened. So it was revealed through the pregnancy that she had a congenital heart defect. And that was manifest through her almost dying, and essentially her ejection fraction dropped to such a point to where it was almost irreversible, and there was hardly anything they could do. She ended up having to have heart surgery. Now has an internal cardiac defibrillator and is restored to health. We couldn't save our precious baby. However, the trust issue comes with how this was all handled. So literally the day before, I rushed her to the emergency room because two doctors outside of the area, mind you, told me it sounds like the symptoms she's having are related to heart disease. And she had gone to 4 different doctors here in the area to try to figure out what was wrong. She kept saying, I think I'm dying. She's coughing away. She doesn't know why. And she's literally choking, to death. And she had gone to a doctor literally that day in the evening, about 4 hours before I rushed her to the emergency room. And he said, this is just pregnancy. You're fine. Don't worry about it. When I took her to the hospital, 2 internists didn't listen to her and basically try to send her home. The only reason I didn't allow that to happen was because one of my friends from Orlando, Florida, said, do not let them send her home without getting an echocardiogram. I didn't even know what an echocardiogram was, but I said, did you do an echocardiogram? They said, no. I said, okay, well, I can't let her go without getting an echocardiogram. And so they finally did, and her ejection fraction was under 20%. And they said, oh my God, you could have a heart attack at any moment. And so they gave her an oxygen mask and admitted her, and ultimately led to the heart surgery. But it didn't stop there. The next day, after she, thank God, woke up, 2 cardiologists came and saw her results of her heart function for that night. And that's when they made the assessments and so forth. And one actually came to her, sat on the bed, and without any sort of caveats, he just asked her, how long have you been doing crack? And my wife was, literally shocked and started just crying. Deep crying. And so he said, well, sorry to, kind of break it to you, but your heart results look like a person who's been smoking crack or cocaine for 20 years. And she, she's working on her PhD at the time. She's Ivy League educated. She's a dean of instruction at Taft College, a local community college, professional, never done drugs a day in her life, didn't drink, none of that. But the assumption and the bias that was part of his assessment to lead with that, she lost a lot of trust and a lot of faith in the healthcare system. And then, of course, too, the 4 doctors who she had seen in the week leading up to this point of near death, they just all happened to be male. And so the response from every single one, none of them listened to her. Every single one said, this is just pregnancy. Oh, no big deal. And then she almost died. All of that to say this, when you don't listen to folks, they don't trust you. And then they blame you often. They will blame African Americans for losing trust in a system that doesn't hear them, that does not affirm or validate their voices, makes all sorts of assumptions about who they are, what their lifestyle is, etc. and that's why I say we still have a long way to go when it comes to culture change. Yeah, there's Tuskegee. My dad brought that up when I told him you really need to get the vaccination, and he said, "But Tuskegee." I said that was a long time ago. We're past that. There are systems in place where that should not be able to happen anymore. So you should have more trust in the system. But he also had experienced terrible interactions with hospitals and healthcare systems in Los Angeles County, living in Lancaster with my mother, God rest her soul. I'll share one other anecdote to talk about how, devastating it was to them both. A year before my mom passed away, she had dementia or Alzheimer's and was starting to lose some of her bodily functions. And so he took her to see a doctor in Lancaster, and the doctor just, the message we all kind of knew, okay, this is starting to run its course and she probably doesn't have a whole lot of time left. But the way he communicated it, he basically looked at my dad and said, "Looks like she's getting out of here." And I remember my father sharing how that was communicated, and my siblings, I'm one of 7, all wanting to know the name of that doctor, and me not being a pastor at the time thinking I might go to jail tonight if I know who this guy is, because I'm going to punch him up. I'm going to do something, because that is not how you communicate to someone that their loved one, who's been married 49 years is potentially close to death. But my father and my mom, very little trust because of how they received messages over the years. This wasn't the first time they had received communication that was just terribly, terribly horrible. And so this trust issue is huge. And I believe it is probably one of the biggest barriers to why women, Black people of all ages and backgrounds and education levels have lower trust in healthcare systems than people of other races, because our experiences are often different. And those are just a couple of personal stories that I have to share. I have more, but I'll stop there because I know we're running short on time.
What steps do you believe can be taken to improve the trust for African Americans within the community?
No, that's a great follow-up question. And really one of the priorities that I see in this role as a Chief Health Equity Officer is, how do we create training and culturally competent training and help shift the landscape so that the system starts to, for one, demonstrate more trust in Black people? Because in all of these situations, the reason that my parents and my wife and myself and others got weird comments, they were all unconscious biases. I don't think that any of the doctors or medical professionals that interacted with them took time to pause and think, wow, this person is maybe, highly educated and has a different lifestyle than what I think I have seen about other Black people in the community. That's the issue. And so the implicit bias or unconscious bias training is critical, but finding other ways to strengthen trust. And really one of the easiest ways is you have to stay connected with populations. Even if you don't have lived experiences, if you stay connected to different people and you actually have a relationship, guess what? Everybody has higher trust. It's beautiful how that works with humans. You connect with folks, you have a relationship with them, and whether you're the same race or socioeconomic status or not, there's higher trust that develops in those relationships. And then it automatically, often those implicit biases start to dissipate. When you learn about other human stories, it's really hard to assume the worst about people who are coming to receive services from you. And so I think those are just a couple of things: training about unconscious bias, implicit bias, and how do you restore trust, but then also, frankly, just more interaction and intentional interaction. And I say on the part of the entire healthcare system. I don't think at this point, because of the history, you can expect, Black folks to suddenly start trying to initiate relationships with random doctors with the hope that eventually this changes. it's incumbent upon us as the healthcare community to change the narrative, to change our assumptions, our beliefs, our biases, so that we can start to increase and improve trust in the relationships with Black folks and with people who have all historically been marginalized or trusted at a different level.
Thank you. Thank you so much. We are running short on time, but I do want to get one last question into to you. And I'm going to pose this question first to Dr. Rodriguez. The last question will be, what are some practical methods to enhance healthcare literacy among the African American community?
I think a lot of it is implementing in all forms, say like in the schools, having healthcare classes. So, and then to do it in a way where you don't even know you're learning it. For example, say STDs, okay? STDs, STIs are higher among, especially we're looking now at rates of HIV among Black adolescents and teenagers and even in the under 40 population. So how do you do that? Well, you could target, say, get the coach on the team, say the high school football team, to have a talk about that, and then bring in a community nurse or a physician there to comment. And then there you build some trust. There you already trust your coach, and you're going to listen to your coach because he's probably one of the most important people in your life at that point. And you're doing the sport that you love, so you're going to make a good connection. And so I think a lot of it comes from trying to get our youth more education, especially in the public schools right now. I know that they have some programs that are implemented, but obviously they're not good enough. You know, I just to touch on something, you know, in my training, I'm actually was trained as a registered nurse, practiced as a registered nurse before I went to medical school. I had more cultural diversity training in my nursing career than I did not have one formal class in my medical school training. Did you know that? And in mine is it's a standard curriculum for the American Medical Association, you know, so there's something in the training of our physicians that is lacking there with cultural diversity. You could try to teach them at the time they've already been a doctor for about 10 years in a hospital, but it's not going to get through unless you're doing it at the level of medical school, you know. So that's one little thing I wanted to add. But I think one thing with health literacy is trying to teach people at all different areas of their life, you know, at the grocery store, having a handout there, having somebody just to educate them about in the area of, like, say, where we have a lot of processed foods, something about diabetes in carbohydrates. They're going to learn very well and fast, and it increases their health literacy.
Thank you so much, Dr. Rodriguez. Same question, Dr. Jackson. What are some practical methods to enhance healthcare literacy among the African American community?
Well, you can improve the spoken communication, use plain language, visual aids, such as models, pictures, videos. If you're working with other organizations, providing explicit instructions, offering only the information that patients may need by limiting the discussion to improve Black health in mind and body. Those two things are imperative. Meet the patient where they are. That is so important. And lead by example. You can make small changes. Don't try to overwhelm the patients. Training with a workforce that resembles the patient population. If you're in a area where it's predominantly of another race or culture, you need to meet those that are, you know, our Black African American people. You need to meet them at, as I say, that crossing the road where they will understand what is going on and they won't be so deterred or frustrated that they don't want to entertain the conversation. Address the social detriments of their health, how important it is, using technology. As she was speaking, Dr. Rodriguez was speaking about in the high schools and things of that nature. Technology is huge. And if you can use that technology to, for example, show them or teach them or have different modules on how they can actually visually see what is going on and how this is affecting them, having all this fast food and stopping in these places, it is good sometimes, but not all of the time. That how it damages, you may look good on the outside, but the damage that it's doing to the inside of the body will provide for fair and equitable health care.
Thank you so much, Dr. Jackson and Mr. Traco Matthews. Same question. What are some practical methods to enhance healthcare literacy among the African American community?
I'll keep it very brief. So again, I think Dr. Rodriguez and Dr. Jackson shared some great tips. The one thing that I would add is just use trusted messengers. Again, back to that key element of trust. Who's sharing the message? Sometimes it's not so much about what is being shared, but who are people willing to listen to? And so a shameless plug for community-based organizations. I think CBOs often have the trust of communities. And if they're the ones talking about these health issues, congratulations. I think COVID taught us that here in Kern County when it came to the vaccine, and the pastors were the ones sharing this concerted, unified message. All of a sudden, folks were masking up, getting vaccinations because they were using trusted messengers. And so I think that's one thing that will help, quote unquote, health literacy. People will just listen at a higher level when you're talking through people who they know, love, and trust.
Thank you so much. I'd like to thank all of our special panelists on the podcast. I am now going to turn it over to Brigadier General Isaac Sandifer.
This has been a very rich discussion, and much has been said and much has been learned. Much more will be learned by those who will view this podcast. And I want to extend my appreciation again to Dr. Rodriguez, Dr. Jackson, and Mr. Traco Matthews.